Hi everyone, welcome to the Futures Leaders Symposium. My name's Katie and I'm going to be your MC today, this afternoon. So I'm an ECR over at Marta Hill. The Future Leaders Symposium is a celebration of the great achievements of the higher degree research students and early career researchers at Marta Research. Each year we come together to celebrate the outstanding contributions of our leaders in the biomedical and clinical research. And this research contributes towards better health outcomes for our community. The Future Leaders Symposium provides a forum to learn about research with impacts at Marta and within the community at large, and to discover how our future leaders are on their journey to address some of the world's biggest health challenges and unmet health needs. I just have some housekeeping to quickly run through with you all. This is a hybrid event, so there's you guys all here today, as well as some people online via Zoom. If you're here in person with us today, we encourage you to wear a mask and maintain social distancing. If we have to evacuate, the exits are at the front and the back of the building, and we just have to meet at the areas between the TRI building and the PACE building. Bathrooms are behind us, so if you go out the back, it's towards the left of the main entrance to the TRI building. A reminder, smoking is not permitted within 5 meters of TRI. And just to let you know, all the presentations are being recorded, and by entering this event site, you agree to being filmed or photographed, which may later be used for marketing or promotional purposes. There will be Q&A sessions, which are limited to 1 to 2 minutes only. And so presenters are requested to discuss their research and respond to any questions, if any, during the networking event during afternoon tea. I'd now like to welcome Loretta Weatherall to do the Acknowledgement of Country. Loretta is a Gallimore woman born and raised in the northwestern regions of New South Wales, including Gundagai and Woolwet. She completed a high school certificate as a boarding student in Sydney and then returned to be closer to family. Loretta has been working as an Aboriginal researcher for over 10 years and was instrumental in establishing the Gomeroi Goyaglau cohort of Indigenous women and children in New South Wales. She led the recruitment, retention, data and sample collection for these participants and began to undertake more qualitative research with communities. Loretta completed her certificate for an Aboriginal and Torres Strait Islander primary healthcare, making her an Aboriginal health practitioner. She spent 2 years working in the Aboriginal community controlled sector in Woolwet and led much of the COVID response testing in their community. She recently joined Marta Research as a senior research assistant with the Indigenous Queensland Family Cohort and Indigenous Research Priority Study. Loretta is passionate about improving health outcomes for Aboriginal and Torres Strait Islander people and looking forward to learning more during her time at Marta Research.
I would like to acknowledge the traditional custodians of the land we are meeting on today. I pay my respect to elders past, present and emerging, for they are the memories, the tradition and the culture of Aboriginal and Torres Strait Islander people across the nation. I ask all people that walk, work and live on traditional lands to be respectful of culture and traditions and work together as one to better Aboriginal health. Thank you.
Thanks, Loretta. I'd now like to hand over to Paul Dawson, who will introduce the John Prins Oration.
Good afternoon, everyone. My name is Paul Dawson. I'm the Marta Research Head of Education, and I'm very privileged to introduce this plenary session named the Professor John Prins Oration. John joined our institute as CEO back in 2009. Back then we were known as the Mater Medical Research Institute, and he was instrumental, key in bringing us together with the University of Queensland to make our institute within the Faculty of Medicine of UQ, and he was the director of MRIQ from 2013. Before moving to Melbourne, he was the acting CEO at Mater. John is a clinician scientist with training in endocrinology in Brisbane before completing a PhD in the Department of Medicine at UQ. I think it's terrific that John, that this oration is named in John's honour, because he really did foster excellence in the early career researchers and PhD students at Mater, and had a major contribution to the recruitment of researchers, and was integral to combining research, biomedical and research and clinical activities here at Mater. So I'm delighted to introduce our oration speakers today. We have a combined clinician-patient presentation today. Our clinician, Dr. Lisa Gillander, leads the Epilepsy Research Group and co-leads the Neuroscience Program at Mater Research. Dr. Gillander specialises in stereo electroencephalography and the surgical management of epilepsy. Her clinical studies are centred around investigating a link between seizure, semenology and autoimmunity, identifying novel epilepsy diagnostics, improving functional MRI capabilities for pre-surgical language assessment, and optimising neuropsychological language evaluations. Dr. Gillander is also passionate about preclinical research and actively collaborates with numerous other researchers, including at the Queensland Brain Institute. I'd like to also very warmly welcome Mr. Casey Lucas and his family who are here today. Casey graduated from the Australian Catholic University in 2021 with a Bachelor in Arts, majoring in literature. In his personal life, he has a love for the arts and sport and is currently pursuing a career in the art industry. Casey was diagnosed with epilepsy in February 2018 at the Mater Hospital, and since then he underwent various treatments and tried a variety of different anti-epileptic drugs with limited success. Casey is kindly here with us today to share his journey from a consumer perspective. Please join me in welcoming Dr. Lisa Gillander and Mr. Casey Lucas.
Thanks, Paul, for the kind introduction, and thanks for the opportunity to have us both speaking here today. It's a team effort.
So that's
so this is obviously a bit of a novel approach to a presentation, and so rather than beginning with some objectives and backgrounds, I wanted to share some thoughts about what I've learned from working with people like Casey and, you know, the journeys that they go through. Patients seek medical care because a problem has occurred. They see a doctor in the hopes of getting a diagnosis. That's the name of a disease and an explanation for what's causing their problem. That usually comes with some kind of diagnostic label, the implications of which can be very multifaceted, and it can mean different things to different people. In addition, what's created that diagnostic label can be very different, and the research behind the disease can vary a lot, so the value of the label is different for different conditions. For example, a diagnosis can provide certainty and direction. It can explain an underlying pathology. It can imply a treatment. Conversely, in other situations, it can have very limited inherent value. It can even cause stigma or discrimination. And it can be temporizing in situations where there's a high degree of uncertainty about what's going on. And that's the situation for Casey. He is affected by something called autoimmune associated epilepsy. And so little is known about this condition that even the name is still heavily debated. And even in my short career, it's been called multiple different things. Specifically, Casey has something called anti-glutamic acid decarboxylase 65 antibody-associated epilepsy, which is particularly pertinent to Professor Prins, because most of the time, we call it GAD65 for short, it's found in cases of type 1 diabetes. But Casey doesn't have diabetes. Also importantly, the levels of the antibody or the blood titers of these antibodies in diabetic cases are usually in the hundreds, but Casey's levels are in the thousands. Even more importantly, it's found in his central nervous system, in his brain, which means that it's highly unlikely it was a coincidental finding, and it has to be relevant to what's going on in his case. As you can imagine, that's got huge implications when we know so little, trying to navigate a path forward, trying to not only find an answer about what this condition is, but how we're going to handle it and how we're going to make things better. For us as clinicians, we have to partner with our patients to try and help them navigate that landscape, translating what's available in the research and filling in the gaps where there isn't any information. And for you as researchers, there's a huge opportunity, a vast chance to improve the lives of patients in real time, doing research that has real world impacts that might change not just the diagnosis, but the treatment, and has the real potential to make things better, rather than living in a situation where you've got nothing more than a confusing label that doesn't give you any kind of direction. This picture here is the first attempt. It was published last year by a group trying to graphically demonstrate the journey of someone after they receive a diagnosis of epilepsy. You can see there that there's lots of ups and downs, and often it's going in the wrong direction. This occurs in the context of epilepsy of a known cause. So you can only begin to imagine what it looks like if you've got epilepsy of an unknown cause, or where the cause and treatment are unclear. That's the situation Casey's in, and I'm very grateful for him joining us here today to hopefully give you a glimpse into the journey he's been through with this diagnosis and how he's handled it, and hopefully find a little bit of inspiration as well moving forward in the various areas that you're researching.
I'm aware that I'm 4 meters tall, so audio is cool. Cool. For lack of a better, more overused phrase, my world was completely flipped upside down on the morning of December 22, 2017. I was driving to work, a little more than slightly hungover, just like any other 20-year-old uni student during the summer holidays, when suddenly I found myself unconscious in somebody's front yard. I didn't know it at the time, but that would be the last time I ever drove a car again. I had the not so delightful combination of both shock and a postictal state. To say that I was confused would be putting it lightly. For all I knew, I was just like any other 20-year-old I knew. Not taking as good a care of myself as I should, but nothing that I ever thought would result in what I later found out to be a seizure. Not that finding out it was a seizure was an easy path either. The frustration I felt pre-diagnosis was immense. Despite my family and I's best efforts, it took months to get a conclusive answer as to what was actually causing my ongoing losses of consciousness. I had more monitoring, tests, and consultations. I didn't spell it right in there. Can you tell I only read it once? I had more, no, I read that, than I care to remember. It was the most difficult part of the last 5 years for myself personally, but it was incredibly, wait, did I? Yeah. Was disheartening. Yeah, I'll leave it at that. I just wanted to return to some type of normality, or if that wasn't possible, at least have a course of action to put in place to adjust to whatever my life was going to be now. During this time, I was tested for Marfan syndrome, as well as a whole other host of other cardiac and neurological conditions. It felt like every test and consultation took me further from actually finding out what the root cause was. It wasn't until I finally had a seizure and made notes about the feelings and sensations that I felt that I had any real sense of what the issue could be. The most predominant sensation that I recalled at the time was deja vu, Well, a quick Google involving something to the effect of deja vu, loss of consciousness, and it wasn't long before I had my GP refer me to the MARTA neurological team, where I ultimately met Dr. Gillander in February 2018. I immediately felt like I was in good hands with the team at the MARTA. I pretty quickly had an EEG and was fortunate enough to have a seizure during the 3 hours I was connected. Actually, having the diagnosis that followed almost immediately was bittersweet. I now knew exactly what was happening, or at least had a better idea than I had in the months preceding. But I was also aware just how invasive and unsuccessful treating epilepsy can be. But the silver lining for me was that my family, my friends, my partner at the time, and I at least had some comfort in having a plan of action moving forward. The real shock came when I was eventually diagnosed with suspected autoimmune encephalitis. If I had no real idea what living with epilepsy meant for me, this was something altogether different. 5 years on, and I don't really feel like I am any closer to that answer either.
So there's a fairly standardized approach to the workup and evaluation of epilepsy, and we look for all of the different causes of seizures. And typically in focal cases of epilepsy, that involves looking for lesions, misfoldings of the brain tissue, vascular insults, infections, things like that, that might have caused some kind of brain damage that results in abnormal electrical activity and then subsequent generation of seizures and epilepsy. Casey went through the works of those evaluations and we didn't come up with any cause. Obviously, that means we need to go looking for other things, and in particular, atypical things or rarer things that don't come up on standard testing. There was also a few other features in his cases which made us suspect maybe autoimmunity was at play, and so he underwent a blood test. That was what first revealed the GAD65 antibody, but that on its own isn't enough to make the diagnosis, even with the titer being in the thousands. So it meant Casey needed to undergo more invasive evaluations in the form of a lumbar puncture. And that's so we can get this. This is cerebrospinal fluid, which is the fluid that surrounds the brain. It keeps the brain in a normal, healthy, homeostatic state. But in pathological conditions, it can also harbour biomarkers of disease. And in this case, antibodies. So we were able to confirm by doing this test that the GAD65 antibodies were present in the central nervous system. And it also allowed us to do a more advanced test using fluorescent means to show that these antibodies were actually attaching themselves to brain tissue, meaning that they were likely responsible for the seizures. We did some other investigations, some fancy research grade MRIs in collaboration with the PA hospital and TRI, but still weren't able to find any other clues. So that leaves us in a situation where we've got a biomarker of autoimmunity, someone who's having recurrent seizures, and we need to formulate a plan of how to move forward. And so we had discussions about what the best treatment approaches were and whether it was worth pursuing something like immunotherapy.
So immediately following that diagnosis, I began receiving IVIG, just up here, with no results to note in the months the treatment was ongoing. Following IVIG, I began to have PLEX, or plasma exchange. I found this particular treatment to be more fascinating than anything else. It was uncanny to leave the infusion clinic at the end of 5 hours and see liters and liters of yellow fluid that had just come out of my body, while also knowing that I was filled with artificial plasma. Again, there were no positive results to speak of at the end of this treatment. It was during this time that the reality of what this diagnosis meant to me really started to sink in. Before the lack of results from these treatments, I was always trying my best to be optimistic that things would go back to how they were. However, I quickly understood that if I wasn't responsive to these treatments, it was very unlikely I would become seizure-free in the immediate future. After only 6 months, I wasn't really prepared to come to terms with what life with no real prospects of a return to normal meant for me. I felt like I had lost the majority of my independence. I felt I was isolated and excluded from my friendship groups, and that I was unable to do so many of the things that I'd taken for granted. I pretty quickly moved back home with my parents and had no real interactions outside of my very, very close circle. which as an outgoing 20-year-old was a massive adjustment for me. The daily effects for me vary massively. Some days I forget that I even have a neurological condition. Others, it's a struggle to get out of bed and make something for breakfast. Be it the side effects of the various medications, the physical effects of having seizures, or the various mental states I've found myself in, it feels like my condition and the way I live with is always changing and evolving. That's not to say it has all been negative though. I've learned a lot about myself along the way.
As you can see, this has been a really difficult road for Casey. And while the treatments he's received are the generally accepted therapeutic approach to this condition, it's so rare that we don't have any high-level evidence and there's no standardized guidelines for clinicians to follow. Instead, the treatments are based on our empiric understanding of the mechanism of these different treatments and the presumed underlying pathologic processes that are involved in this condition. We're obviously in need of more research, and we're motivated by reports from other centres where there's been dramatic responses to the use of immunotherapy, and in some cases, even a cure for this epilepsy subtype. But of course, we always need more data. Our group has been really lucky to work in this area, and we've published a few different papers due to the generosity of people like Casey, who give us their time, their data, and sometimes their blood and CSF samples so that we can try and study this condition to understand better how it's caused and what we need to do to treat it better. A few of the pivotal things we've found, this is the most important paper. Like Paul said, semiologic associations in this condition, we were the first to report this in the world, and subsequent groups from various centres globally have found similar sorts of things. So particular seizure signs and symptoms can be more likely to be associated with autoimmunity. And so it means we know if we have a patient in the clinic with these symptoms, we're more likely to test for autoimmunity. And there's currently a large study underway to help try and confirm this finding in a much larger group. We've also looked for biomarkers in collaboration with Associate Professor Kristen Radford's group here at TRI, looking at blood and CSF cytokines and chemokines, trying to find, can they give us some clues about the pathology, but also can they guide treatment? And we found two particular markers in this study, which again is preliminary, but guide us in the direction that we might need to be looking in. And also one in particular, there's already a treatment available for that option. So again, there's now a larger multi-center international study investigating this further to see if it can be confirmed and if we can justify pursuing those sorts of treatment options. We have another study which will hopefully come out in the next month or so, where we looked at EEG or brainwave biomarkers. And again, that confirmed the perisylvian association and gives us more clues about how to correctly identify these patients so we can offer them the right treatments. And then finally, looking for other novel biomarkers, other novel autoantibodies. And again, there's another international multi-center study that's evaluating this. And because it's so rare, we can only really be successful in this space if we're working together. So we're really lucky to have these sorts of collaborations set up. Casey also underwent some experimental treatments. He even went all the way to Switzerland. Myself and my colleague actually went through his notes from the Swiss clinic and had quite a time translating Swiss German to try and understand the types of approaches that they took. Some were based on research, some less so, but I think this really speaks to the gravity of the kind of situation that these people find themselves in, because we don't have enough evidence around therapy and the types of different approaches that people will take in the search for a cure or even an improvement.
As for the ongoing clinical trial that I'm a part of with the research team at the Mater, the morning that it was even suggested as a possibility with Lisa, it was an incredible feeling. Long before I had even given consent and gone through all the pre-screening, I at least felt like there was something new to try after over 3 years of no real changes in my treatment plan. I hadn't really I hadn't really had any hopes of things changing for me. I was just trying my best to make the most of my situation. Even if I am quite pessimistic in nature, I was just so excited to have something new to try. I was so wrapped up in these emotions, I almost didn't even feel nervous at the prospect of having brain surgery. Having said that, I was also blatantly ignorant of how it would affect those closest to me. If I could change anything about the months preceding, it would just to try to understand the apprehension that everyone else around me seemed to be feeling. I now really feel like I have the potential to be part of something much bigger than myself. I can't help but dream that maybe one day having these devices implanted in me will be standard procedure for the millions of people out there struggling with epilepsy. I really hope that by being a part of this study, I'm providing data and information that will be able to help those people, because I understand just how crushing it can be to live with epilepsy.
Just some final thoughts to conclude. We talked a lot at the beginning about diagnostic labels, and while they provide us an economy of expression, they risk implying certainty where it just doesn't exist. And I think Casey's story is a perfect example of that. It means that to find a way forward, they have to navigate themselves through the frontiers of medical science. As clinicians, we do the best we can to help them find the right way forward and to help them make the best choices for their medical care. I hope as researchers you can be inspired by Casey's bravery in sharing his story here today, and that in whatever research field you're pursuing, be fearless, shoot for the stars, ask difficult questions, move things forward. There are people counting on you, but also you have the opportunity to work in these really exciting fields, but to also make real world changes for people to improve their lives. And maybe even one day we can achieve a cure. We have the potential to make sure that diagnostic labels are more than just an exercise in semantics, that they can provide real meaning and real hope to patients, as well as improved understanding and directions for clinicians. Thank you.
Thank you, Lisa and Casey, and especially to Casey for this openness and sharing his story with us. Paul's just going to give them our little potted plants as a gift for their time today. And then I would just like to invite Christine Andrews to come up. Christine's going to chair our next session on the ECR Seeding Grants finalists.
Thanks, Katie. So the Early Career Researcher Seeding Grant Scheme is designed to build capacity and provide research opportunities for early career researchers at Mater Research. The grants assist successful applicants to be competitive on a national and international level through applications to major funding bodies such as NHMRC and ARC. 2 competitive seeding grants valued at $15,000 each will be awarded, one for a clinical or health services project and one for a biomedical research project. So the 4 finalists presenting today have been selected by a scientific review panel. The selected projects aligned with at least one of the 3 Mater Research strategy themes, those being discovery, translation, and integration. We're very fortunate today to also welcome a Mater Foundation judging panel, and this consists of Miss Judy Renouf, Mr. Darren Armstrong, and Miss Ruby Dollar. The panel will decide the awardees of the 2 grants during a judges' deliberation session, which will be shared by Professor Paul Dawson. So the first 2 speakers are finalists for the Clinical Research Seeding Grant. And our first speaker today is Dr. Grace Branjaporn. She's a clinician lead of the Mental Health, Alcohol and Other Drugs, focusing on the setup of the Catherine's House for mothers, babies and families. Grace is an occupational therapist and completed her PhD in 2021. She was a recipient of the 2021 Betty McGrath Scholarship to develop a mindfulness intervention to women in the peripartum. She's published over 26 peer-reviewed articles and was an invited speaker in TEDx UQ. Please welcome Grace.
I'd like to tell you about Sarah. Sarah is a 29-year-old woman and she is a first-time mother. She recently birthed at the Mater Mothers Public Hospital here in South Brisbane, and she is receiving a home visit from her midwife at 6 weeks after birth. During the visit, her midwife notices that Sarah is teary and flat, and she finds out that Sarah has been crying all week. Sarah also reports that she hasn't been sleeping or eating and that she doesn't have a strong bond towards her baby. To cope with her struggles, Sarah has been self-harming, and she also regularly has thoughts of harm towards her baby. Sarah's midwife thinks that she is likely to have depression in the postnatal period, which is the time after birth. Sadly, Sarah is not alone in this. The time before and after birth is called the perinatal period, and it is the most high-risk time in a woman's life for her to develop a mental health problem for the first time or experience a relapse of a prior mental health problem. Even disturbingly is that suicide is the leading cause of death for women before and after birth. Statistics also show that 1 in 5 women will experience depression and anxiety in this time, which means that it is so common. Many women also experience a range of different mental illnesses that are serious, such as eating disorders, bipolar disorders, as well as schizophrenia. What women require in this time are the right services at the right place, at the right time. However, this is not the case. Currently, care is fragmented, whereby women have to go to different providers to receive different services, such as going to a psychologist on one side of the city and then going to a psychiatrist across on the other side. This system is hard to navigate and it leaves women vulnerable and falling through the cracks. Secondly, for women who require inpatient 24/7 care, such as Sarah, they are more than likely to be admitted to a mental health general unit where they are separated from their baby. This is detrimental to the mother-baby bond, as well as to the baby's overall growth and development. So here at Mater, to combat these 2 problems, we are revolutionising the way that we deliver perinatal mental health care. We will be currently refurbishing the convent to make it a state-of-the-art facility called Catherine's House, where we can provide state-of-the-art perinatal mental health support. We will be providing wraparound support for mothers, babies, and their families so that they can attend an inpatient mother-baby unit where they can receive inpatient psychiatric care with their baby so it supports their bond as well as their mental health. Once home, mothers and families will receive psychology, mental health nursing, physiotherapy, breastfeeding support, psychiatry, GP support, as well as trained volunteers that come into the home. In essence, we are providing a one-stop shop so that care is coordinated, integrated, and it is all under the same roof. Not only will there be inpatient services, but families will be discharged home and receive ongoing support through a range of different community programs. You would think that this type of care is standard practice, but actually this is the first of its kind in Australia. We believe that this will work, but we need research in order to prove its effectiveness so that we can replicate it not just here at South Brisbane, but also around Queensland and around the world. So my research will track families over time in a longitudinal study so that we can see how they're going when they first come in, when they are discharged, as well as 6 weeks, 6 months, and 12 months after their stay, so that we can see not only the short-term outcomes, but the longer-term outcomes as well. There are different outcomes that we are looking at, such as how mum improves with her bond towards her baby, the quality of life as it improves, as well as the value for the healthcare service, the way that the mother and the baby interacts with each other, as well as alleviating depression and anxiety. We'll also be looking at how this type of service boosts a parent's confidence. By having this research, we will be the leaders of perinatal mental health care and research, and MARTA will become a centre of excellence in perinatal mental health care so that we can integrate and translate research into everyday practice. And MARTA is ideally placed for this, as we are already the largest maternity hospital in Australia. This type of research also enables families to have the best start for all, so that we can give everyone the right foundations in this critical time of life. So to end, I'd like to thank the MARTA Foundation for its generous donation in changing vulnerable families into thriving families.
Thank you, Grace. That was magnificent, and it's so exciting to hear about that construction that's going on, to see what's actually going to be in there. Don't run away though, because we do actually have time for 1 or 2 questions. Is there anyone from the audience that has a question for Grace at all? Brian.
Yeah, it's a wonderful initiative. Just in terms of the postnatal depression, is that really around the expectation that all mothers have that they will naturally bond? And if that doesn't happen, does that drive a lot of that depression and everything else?
Yeah, that's a really good point with societal expectations, thinking, oh, you know, similar to Kate Middleton, the way that she can just give birth and be happy, that, you know, you look through social media such as Twitter, Instagram and Facebook, and you only see the happy photos of mums and babies together in a play group, or the beautiful idyllic photos. So yes, it could be as well societal expectations and the media pressure as well. There are also a range of different hormonal changes that occur with the birth of a child, as well as a range of different other psychosocial factors, maybe domestic and family violence increasing, social support from dad or partner changing as well, maybe differences of going from just a woman to a mother, so that role change as well, maybe changing from, you know, different careers as well to becoming a mother, as well as perhaps it then arising, they're triggering different previous mental illnesses in the past, or the way that their parent raised them as well.
Thank you. One more question from up the back.
So this is, as you said, a new model of care. What do you predict is the highest risk point in this new model, and will you be focusing your attention on that risk point?
The highest risk point. So as you know, suicide is sadly the leading cause of death in the perinatal period, in this time before and after birth. And we also know that infanticide, which is death of a baby, is also another high risk point. So risk towards the mum as well as risk towards the baby. And so in this inpatient mother and baby unit, where mums and babies can be together in this new model of care, we'll be providing really high ratios of nurses as well as different multidisciplinary staff, so that we can better support women and provide novel care and novel treatment approaches that will support women to be able to recover in their mental health as well as bond with their baby. And so through this, we'll be able to then provide that wraparound safety.
But do you think the highest risk point is when they're acutely sick and they are first admitted, or in that transition phase back to home, or when they're transitioning to be less dependent on this high level of care?
So we know that that time after going from 24/7 care, which is where there's lots of people around them that can support them, then going to perhaps their home where they will have less care, perhaps not less social support as well. So we know then that 7 days and that 3 months as well after discharge is the highest risk point. And that's why we'll be providing a range of different community services, so they can stay out of hospital, they can stay well in the community, they can be with their family, and they can get support as an outpatient person.
Thank you, Grace. And thank you. I think That's time for our questions at the moment. Just wonderful. Let's thank Grace again. So the second finalist for the Clinical Research Seeding Grant speaking today is Dr. Tylen Gagensky. Tylen is a MARTA Palliative Care Research Fellow. He's nearing the end of his advanced training in palliative medicine and is also completing a PhD through UQ, which considers aspects of evidence-based symptom management in advanced cancer. Prior to his palliative medicine training, he was a uniformed general practitioner in the Australian Defence Force and subsequently in private general practice. Please welcome Tylen.
Thanks very much for that introduction. Look, I'd like to start by telling you a story. Lydia is a 67-year-old lady with metastatic kidney cancer. She's had chemotherapy and unfortunately it's no longer working. She's told us, her doctors, that what she liked most with the time that she has left is to spend time with her husband, her children, and her grandchildren. She especially likes to go down to Wynnum and spend time by the water and feel the sun in her face. Unfortunately for Lydia, she starts to develop fevers, and fevers in cancer are a big deal. They could herald a life-threatening infection. So of course, our advice to her is to come into hospital. She comes in and she gets scanned from head to toe in the emergency department. And even though the cancer is not the thing we're interested in, she asks us, has the cancer changed? And we tell her it has. And you can see that it hurts, and it hurts her husband too. She comes in and every time she gets a fever, she gets a blood test, and it's always the most junior doctor in the hospital doing it. And it hurts, but she doesn't complain. And she gets intravenous antibiotics and it makes her feel nauseated, but all she says is, look, it's not as bad as the chemo, don't worry about it. At the end of that 6-day admission, all we can tell her is, look, Lydia, it's probably not an infection. It's the cancer that's causing the fever. Cancers do that sometimes. Now, that's not the worst part. The worst part is that's 6 days for someone who's only got a few months left. And when she goes home, she's probably going to have another fever. And we don't have a crystal ball as doctors. We don't know if it's the same or different. And so we'll ask her to come back again and again, rather than spending time with her family. And of course, that's not what we want. What we want to do, and that's what this project is about, is help patients spend more time with their loved ones and less time at hospital by preventing these cancer-related fevers with naproxen, which is an anti-inflammatory medication. So how does it work? Look, in the cancer ward where I work predominantly, patients get fevers all the time, and sometimes they're from infection and they get better with antibiotics. Sometimes, like Lydia, we do lots of tests and we can't find the cause. And this group of patients have what we call neoplastic fever, which is just a fancy way of saying fever caused by cancer. And our goal is to use naproxen, which is an anti-inflammatory medicine like Nurofen, to prevent them. Now, when I told my dad about this thing, he's an engineer, not a doctor, and he thought, look, that sounds really good, but won't you be preventing, won't you be stopping yourself from being able to notice that they have an infection as well? It's a really good question, and you're probably asking yourself the same thing. Fortunately, there is previous research to suggest that whilst naproxen does or may reduce cancer-related fevers, it has no effect on fevers due to infection. So I guess a lot of the time as clinicians, we come up with these ideas for projects and they're really expensive with really fancy drug targets. And at the end, either it doesn't pass safety or there's some other problem with implementation. With naproxen, on the other hand, an old drug, we know what it does to the body and we know how it does it. It's a $1 medicine to prevent $1,000 a day hospital admission. It's a $1 medicine to prevent the chance of hospital-acquired infections for these patients. And it's a $1 a day medicine to let people spend their time with their loved ones and not at hospital. I think repurposing an old tool to fix a new problem is healthcare discovery and innovation at its best. So how does naproxen work? Look, cancer makes chemicals which trick immune cells into getting angry or inflamed. And when they get angry and inflamed, they cause fevers. Naproxen, which is a non-steroidal anti-inflammatory, stops these chemicals from being made by the immune cells. And so it stops the fevers from happening. And it doesn't take a lot of naproxen either. It's the same amount that you take for knee pain or a headache. Are these fevers common? The answer is yes, they are. And they're a big deal. This graph, the highlighted column, looks at the cause of fevers other than infection in patients with cancer. And you can see the most common cause of fever in these patients is tumor or the original cancer. And another very common cause of fever in these patients is metastasis, so where the cancer is spread to somewhere else. Together, these make up over 30% of the fevers in the patient group of interest. That's 30% of patients with all these wasted days at hospital with not much time left. And that's what we're trying to prevent. MARTA is the right place to try and fix this problem. We've got a lot of expertise in oncology. In the centre here, we've got Professor Janet Hardy and Professor Philip Good, who are very experienced and accomplished researchers and clinicians in the area of oncology and supportive care. They also happen to be my PhD supervisors as well. And we've also got Matthew Spitzer and Georgie Huggett, who are valuable parts of our research team. The MARTA Cancer Care Centre itself is one of the best oncology units in the country, and the MARTA Foundation has again and again shown its willingness to help fund research which changes this very vulnerable group of patients' lives. So I guess back to where we started. What we want to do is prevent patients from spending their time in hospital and instead spend their time at home. I think we can, and this trial will provide proof of concept for our protocol and help us secure further funding to run a large-scale randomized controlled trial to show whether this idea works in practice. Thanks.
Thanks, Ty. That was a fantastic presentation. I wonder if there's any questions from the audience. Oh, over here. Fabulous. Down the front, please.
That was a great talk. Just want to ask you, will you be looking some biomarkers or something in patient sample before giving the drug or after?
Yeah, it's a really good question. So the question was, we're going to look at any biomarkers. Look, we intend to. In a separate trial, we're looking at cytokines, and we're lucky enough to recently make contact with Mania, who is in researching inflammatory bowel disease here at TRI, and I may get in touch with him to see if he'd be happy to work with that too. It's certainly an area of interest.
I have a question, if I may. I'm also wondering, what are your key outcomes that you're looking for in this study? What are the main things that you're interested in measuring?
Yeah, it's a really good question. I think we have to be realistic with what we can accomplish with a small grant. So our key outcome is the recruitment of patients in a palliative care setting for the trial. And in palliative care, it's not easy to even run a trial at all. So to be able to show that your protocol will recruit patients and generate data is really important. Our secondary outcomes will be things like cytokine profile in patients with fever, and also, of course, the effect on fever with naproxen, although that's quite well supported through the literature. So we're not expecting to see anything too new or surprising with that.
Excellent. One more question.
Thanks for the excellent proposal, Tyler. And just a very ignorant question, no doubt, but will you be comparing naproxen to any other groups or treatment groups like paracetamol? As you know, obviously a lot of these patients with palliative conditions might have underlying chronic kidney disease or things that might contraindicate the use of NSAIDs. Are you planning to include a comparator group like
Yeah, it's a really good question. For this grant or for this protocol, no. We would exclude patients with chronic kidney disease and also patients with hematological malignancies whose risk of bleeding with NSAIDs is just a bit too high. Again, it's proof of concept to show that we can recruit for this sort of very difficult to run population. The other thing to note, I guess, is in trials in palliative care, particularly with patients that are quite sick, the attrition rate, which unfortunately means the rate at which patients are too sick to continue the trial, tends to approach 20 to 30%. And so we need to demonstrate, and these are a bit sicker than the usual sort of trial population, even in palliative care. And I guess we want to show that the protocol is still workable, and in the future work towards a multi-arm trial with naproxen versus either placebo or a different anti-inflammatory or a corticosteroid.
Thank you. Thanks, Ty.
Thanks.
Oh, please thank Ty. So our next two speakers are finalists for the Biomedical Research Seeding Grant. First, we have Dr. Natasha Jantz. Natasha joined MARTA Research in 2021 to study retroviruses. She has a background in molecular epigenetics. She was awarded Human Frontiers and EMBO postdoctoral fellowships to train at the Helmholtz Institute of Epigenetics and Stem Cells in Munich. In 2021, Natasha joined Professor Jeffrey Faulkner, supported by an NHMRC investigator grant, to investigate the epigenetic mechanisms governing retrovirus regulation in infectious and malignant disease. Please welcome Natasha.
Cool. Can everyone hear me okay? Yeah, cool. Thank you, Christine. And thanks to the foundation as well for the chance to tell you about my research today. So this talk is taking place on the unceded Yagara and Turrbal lands today, and I want to acknowledge all elders, Aboriginal and Torres Strait Islander people here in the audience today, and importantly, the Aboriginal people who have contributed to and continue to contribute to the research I'm going to tell you about today. So I work on a little known virus called HTLV1. And even though this virus was discovered over 40 years ago in 1980, it didn't really make global headlines until a couple of years ago, when it was found that HTLV1 is found at unprecedented levels in remote communities in Central Australia. So this prompted a call from the World Health Organization and many other health bodies for more research, public health measures, and investment into understanding HTLV1 and its impact around the world. So HTLV1 is human T-cell lymphotropic virus type 1. It's been identified in 20 million people around the world, although we think this is a gross underestimate because it's not routinely tested for. And it predominantly infects and affects Indigenous peoples in the global south. It's a chronic virus, so once infected, the patient will carry it for life. And it results and manifests in a range of different diseases in a suite of organs throughout the body. So most commonly, it manifests in an aggressive and very fatal leukemia called ATL. It can also cause a degeneration of the nervous system, leaving patients wheelchair bound, and inflammation of a number of different organs. But I'm predominantly going to focus on inflammation of the lungs, known as bronchiectasis. So as I mentioned, Australia is burdened with an incredibly high rate of this virus, the highest in the world, such that patients, Aboriginal patients that were screened for this virus in Bundoora Hospital, it was found that 33% of those patients were carriers for the virus. And when individual communities were tested, up to half of the population, so 1 in 2 people, carried this virus. Here on this continent, it most commonly manifests as this inflammation of the lungs or bronchiectasis. But regardless of the disease manifestation, it's associated with an increase in mortality. So one of the reasons this virus is such a huge burden for the communities affected by HTLV1 is that there's currently no cure or treatment for HTLV1. So to understand why HTLV1 is so long-lasting and hard to treat, we actually need to think about the molecular process that happens when this virus infects a cell. So when HTLV infects someone, the virus particle finds a T cell, which is its target cell, and it releases its genome into that cell. Once in the cell, the HTLV1 genome actually goes and finds the host genome and integrates itself permanently within the host DNA, such that this virus and this viral genome will stay in that host cell for the lifetime of that cell. So the outcome of this process actually varies depending on how and where the virus integrates. So we know not all parts of the genome are made equal. So there are some parts of the genome that are particularly active and they produce and turn on lots of genes. So if the HTLV1 genome integrates into one of these active parts of our genome, it will also be turned on and activated, producing lots of copies of the HTLV1 virus genome and lots of virus particles so that it continues to propagate and spread. However, if there's a lot of viral production, our immune cell can actually detect the virus and start to clear it away from the patient. On the other hand, if the virus finds itself integrated into a part of the genome that's not particularly active and not turning on genes, the HTLV1 genome will also be switched off and not activated. And while it won't produce lots of virus particles that will allow it to spread and propagate further, it will be able to avoid detection by the immune system and persist for a very, very long time within that patient. So in order for HTLV1 to persist within patients and to spread within groups of people and populations of people, it requires a balance, and a very delicate balance be achieved between these inactive and active states. And because this balance is so delicate and important for the viral persistence and survival, this is something we're really interested in understanding better, so we can potentially target it and alter the course of this virus persistence and survival. So to this end, my research is going to ask 3 questions towards better understanding HTLV1 activity once it's integrated in the genome. The first question is a really simple one, but it's what does the virus actually look like in patients? So we know that viruses, once they're in a population, mutate, and these mutations can change their behavior, much like we've seen with COVID over the last few years. So we're going to ask a similar question in patients. What does this virus look like once it's integrated within a host genome? The next question is, where does the virus hide within the patient genomes to allow it to achieve this optimal balance between active and inactive states? So are there particular genomic postcodes or localizations that are preferable for achieving this balance? And finally, can we identify host factors, so factors that we have in our cells that can actually turn on and off this virus? Because these might represent attractive therapeutic targets. So with all this in mind, we're hoping that this understanding and this knowledge game might help us to be able to disrupt this balance between active and inactive states and drive the virus out of hiding so that our immune system can clear it away. And ultimately, we hope that this knowledge could lead to an innovative approach towards targeting HTLV1 in patients so we can reduce the high numbers found here on this continent. So thank you, and happy to take any questions.
Thanks, Natasha. Do we have any questions? Yeah.
Thanks, Natasha. You mentioned 3 different syndromes, HAM, ATLL, and bronchiectasis. Do patients get all 3 or 2 of them? And if they don't, do you know the reason why they're mutually exclusive?
No, so they do. They are mutually exclusive. At least in the literature, there hasn't been cases of them co-occurring. And no, that is a really big question in the field still, is why do patients get different manifestations of disease? And actually, there's a handful of patients around the world that are asymptomatic as well and remain asymptomatic for life, or at least haven't had identified symptoms linked to the virus. So these are big questions that want to know. And actually, in our study design, we're going to have virus from people with different symptoms and asymptomatic carriers. So maybe some of the molecular features we're tracking could underlie the different manifestations. Thanks.
Up the back, thanks.
Thanks, Natasha. That was great. Has there been any other well-known viruses where targeting this activity of them has shown to work?
Yeah, that's a good question. So not targeting the activity in this exact way. So it's interesting, this virus is actually quite closely related to HIV and other retroviruses. But those antiretrovirals don't work on this virus because it replicates using a very different mechanism. And so that's why this virus sort of needs a very innovative approach for targeting it for treatment. And that's why we're trying this new approach, because it's very targeted to the specific mechanisms of this virus and how it replicates.
Excellent, thank you. One last question down the front.
Thanks, Natasha. Just wondering, does the viral DNA has potential to transpose to more active parts of the DNA?
So the question was, for those online, does the viral DNA have the capacity to transpose to more active parts of the DNA once it's in? Yes, it does. So sort of comes back to the questions we're asking. So once the virus is in cells, it actually mutates quite quickly. It's been found with similar viruses like this one, and they lose their capacity to continue jumping and being mobile. So that's one of the first things they lose. And it's been found in some patients for this virus that there's only one copy per cell and it stays mobile and it stays clonal. So very early on, post-infection, yes, that's a possibility, but it doesn't seem to be something that happens as the disease progresses.
Thank you so much, Natasha. So our final speaker in this session is Dr. Simranpreet Kaur. Simran's research focuses on improving the success rate of bone marrow transplantation and developing novel vascular stem cell targeted therapies to treat blood cancers and age-related blood disorders. Her key achievement is the discovery that bone marrow immune cells called macrophages are resistant to the lethal doses of irradiation and are necessary for bone marrow transplantation success. Her work is published in top hematology journals, and she's currently co-supervising 2 PhD students. Please welcome Simran.
So aging is a complex process which is influenced by genetic variations, environmental factors, diet, and nutrition. Along with aging come various diseases, including blood cancers and blood disorders. Now, this graph here shows that age-related blood disorders increases after the age of 50, and about 65% of the patients which have these diseases are between 60 to 70 years old. Now, there are several treatment options to cure these diseases, but there are several life-threatening risks and side effects associated with these treatment plans. Moreover, to treat these blood disorders is very expensive. For example, leukemia, which is the most common type of blood cancer, itself costs around $51,000 per case. And around 90% of the health system expenditure is just used to treat cancer only. Now, despite the availability of such expensive treatment options and years of research that we have been doing to cure these diseases, the death rate of the patients which have these diseases is slowly increasing over the last 10 years. Therefore, clearly, better therapies are required to cure these diseases and increase the survival rate of these patients and improve their health and life. Now, our body every day produces around 200 billion red cells, 10 billion white cells, and 4 billion platelets. And they all flow in these tube-like structures called blood vessels, which are found everywhere in our body. Now, have you ever wondered where and how these blood cells are formed? Well, remember when you go to a butcher and you see a chopped bone, you see a cavity which is filled with a soft tissue. This soft tissue is called bone marrow, and that is where all your blood cells are formed by a single cell called blood stem cell. Any defect in that blood stem cell or during the production of blood cells can cause cancer or a disorder. Now, bone marrow also consists of large number of blood vessels, which not only provides oxygen and nutrients to the bone, but it also supports the blood stem cell function to make the different blood cells of the body. During aging, these blood vessels decrease significantly in number, and the blood stem cells become non-functional, which increases the risk of age-related disorders. Whereas when there's a cancer, these blood vessels increase massively, and in order to support the blood cancer cells and then provide them nutrition to grow further. However, if we can manipulate these blood vessels during aging of blood cancer, we can preserve the function of blood stem cells and reduce the age-related blood disorders, and also starve the cancer cell to death by removing away their source of nutrition. But to do this, it's very important to know first how these blood vessels are formed. Well, they are formed when the mature specialized endothelial cells fuse together to form tube-like structures. And recently, another stem cell population called endothelial stem cells have been found in various organs, which can give rise to these mature endothelial cells. but whether this endothelial stem cell population is found in bone marrow is still not known. In bone marrow, there are mainly two types of blood vessels. One is arteriolar and another one is sinusoidal. The arteriolar blood vessels supports the blood stem cells in the resting state, whereas the sinusoidal blood vessels support the blood cells actively to form another blood cells of the body. Now, my research will focus on three main things. Firstly, it will try to identify this endothelial stem cell population in the bone marrow. Secondly, it will try to investigate how this endothelial stem cell population give rise to these different blood vessels. And thirdly, it will also investigate how this endothelial stem cell population directly or indirectly support the function of the blood stem cells. Once this population is identified and we know its function in the bone marrow, this population then can be targeted to increase the blood vessels during aging and reduce the risk of age-related blood disorders. And similarly, when there's a blood cancer, when the blood vessels increase massively, this endothelial stem cell population can be targeted to reduce the blood reduce the blood vessels and starve the cancer cells to the death. Overall, this research will increase our knowledge of how blood vessels are maintained during aging, blood cancers and disorders, and it will also discover novel ways of preserving the function of blood stem cells during aging to prevent age-related blood diseases. Also, understanding of the OA will lead to discovery of new treatment options to cure the blood cancers and disorders, and this will help us to improve the life of the cancer patients and their survival rate. And I'd like to thank everybody who's involved in this research and Malta Foundation for supporting us, supporting the past and the present research. And thank you to the audience for listening, and I'm happy to take questions.
Any questions from the audience?
We'll have so he's asking how the macrophages are involved in regulating the blood stem cells. So the bone marrow, like I said, also supports blood stem cells, and macrophages are found abundantly in the bone marrow. And it has been already shown, the blood stem cells, there's a niche, there's a home, and there are different cells, that support the blood stem cells, and macrophages are one of them. So, if you deplete the macrophages, the blood stem cells, they sort of, they just leave this home and go into the blood. So that's how they support that. Yeah.
Any other questions from the audience? All right, I'll have a stab at a question, not my area, but I'm wondering, you mentioned you're specifically targeting this group of stem cells. Why is that better than currently what's been happening in this area?
So current treatment options, they target the growth factors, that helps in growing these blood vessels. But the problem is this stem cell population is still there, so even if we target the growth factors, this stem cell population can still increase the blood vessels when there's a cancer. So that's why we think if you can target this, that will help in not increasing the blood vessels, and that will prevent the relapse of the cancer.
Thank you, Simran. Can everyone please give her a round of applause? Okay, so I'd like to thank all the speakers in this session, and I'd also like to thank our Marta Foundation judging panel, and hand back over to Katie.
Thanks, Christine, and thanks again to all our finalists. I'd now like to invite Kylie to come up, who's going to chair our next session, on which is our HDR students.
Thank you, Katie, and good afternoon, everyone. My name's Kylie Alexander, and it's a my pleasure to introduce the Higher Degree Research Travel Award presentations. So these are competitive awards given to our HDR students, and it helps with conference expenses. So they are able to disseminate their research at both international and national conferences. These awards also provide support towards additional costs, such as to visit labs for future job prospects. All applications in this category were assessed by a committee of 5 judges from Marta Research. The top HDR Travel Award honours the memory of Dr. David Cerizio, and this is valued at $5,000. Dr. Lucy Burr has put together a short video in memory of Dr. David Cerizio.
Hi, thank you for inviting me to speak about Associate Professor David Cerizio, the namesake of this premier award. I'm Dr. Lucy Burr. I'm a respiratory physician here at the Marta Hospital. So David was a respiratory physician here at Marta, and he was a true rising star, both in the clinical and in the research world. I first met him when I was a specialist respiratory trainee, again here at the Marta in 2011, 10 years ago. He was a passionate clinical supervisor and a dedicated physician, which was exemplified by his work with his cystic fibrosis patients. He was incredibly caring and taught me how to practice medicine with empathy and humility, even when having difficult end-of-life conversations with young people suffering with disease. Despite his heavy clinical load, at the time he was Director of Physician Training at the Marta, Director of Respiratory Medicine, and also Chair of several committees, including in the Lung Foundation Australia and the Thoracic Society. He was also leading the first Australian study investigating the role of erythromycin, a macrolide antibiotic, in the treatment of bronchiectasis. Bronchiectasis is a severe lung disease characterised by inflammation, infection, sputum production, and cough. This landmark study was published in 2013 in JAMA, a very prestigious journal, and it sprung David really into the forefront of global respiratory research. The samples collected during the BLESS study supported at least 2 PhD students, including myself, with David nominated as principal supervisor for both. The unstoppable David then set up Marta's first respiratory biobank, a diverse repository of clinical samples from patients suffering from respiratory disease, which is still ongoing and currently supporting research into COVID-19 vaccines, as well as treatments for cystic fibrosis infection and lung cancer. David was also instrumental in setting up the National Australian Bronchiectasis Registry, which is currently thriving with nearly 2,000 participants 5 years on. Sadly, David passed away suddenly and tragically at the age of 45 back in 2015. He left behind 3 beautiful children, the oldest of which was only 8 at the time of his death. It has been my honour to help carry on some of his work here at the Marta, and I'm delighted that this award has been named in his memory. Congratulations to the winner this year.
So our first speaker today is the winner of the Dr. David Cerizio Award, and it is Jennifer Stables. Jen is a PhD student in the macrophage biology group, where she is characterising a preclinical model with a mutation that is known to cause a rare form of dementia in humans. Jen recently represented Marta Research at UQ's 3-minute thesis competition and has served on the Marta Research Student Committee and the Faculty of Medicine Equity, Diversity and Inclusion Committee. Please welcome Jen.
Thanks, Kylie. I am delighted to receive the Dr. David Cerizio Award. I actually began my research journey in respiratory neuroscience, so it's really special to have received it. I will be using this award to go to a conference called Neuroscience 2022, which is the neuroscience conference of the year, with more than 30,000 attendees. I can't even imagine what that's going to be like, in San Diego in November. I'll participate in 5 days of networking, learning about the most recent developments in my field, and of course, a lot of professional development. I will also be using this award to visit multiple labs at University of California, both in San Diego and UC Irvine, some collaborators of ours that we've published with, and researching my options for where I would like to go next, because the end of my PhD is rapidly running towards me. I will also be going down to Melbourne and the University of Adelaide to present my research to prospective future labs. But what is my research? Well, I study microglia. These are the immune cells of the brain. Microglia need one protein in particular that my lab's interested in, called colony stimulating factor 1 receptor. In 2011, it was discovered that some humans have a single mutated gene of CSF1R, and that this results in a form of early onset dementia. My patient samples are very rare, and I will never see any in my lifetime. So to understand this disease, we needed a preclinical model. My lab created this preclinical model, and I've been characterizing it. So normally you produce good functional CSF1R, but these patients produce both functional CSF1R and a mutant protein of CSF1R. And what I found is that this drastically reduces the downstream signaling when it's activated, so they don't get the signal that they should. You can see here what microglia should look like with 2 healthy copies of the protein. But if you have the healthy copy and the mutant copy, the microglia look very different, and this is indicative that they're not functioning as they should be. Now, multiple sclerosis patients experience movement difficulties and abnormal sensations, among other symptoms, that result from lesions within the central nervous system that's been caused by an immune attack. Microglia, although we need them, are thought to actually worsen the lesions within the brain. And so it's been proposed that by inhibiting that protein I was talking about, CSF1R, it could be a useful therapeutic strategy for relieving or preventing symptom progression. Given that we have a model where this signaling is already drastically reduced, I wanted to test my hypothesis that this mutation might alter disease onset and progression in a model of multiple sclerosis. So I induced a multiple sclerosis equivalent disease in our preclinical model where there was 2 different genotypes. So like you and me, the normal CSF1 receptor, or the genotype where you would have the regular CSF1R and the mutant CSF1R. I found that throughout clinical scoring and monitoring, there wasn't actually a significant difference. And when I added up the clinical score at the end of the model, again, there wasn't a significant difference between the genotypes. I also looked at the motor skills using an accelerating treadmill, and again found that at every trial there was no significant difference. And on that very last day before I stopped my studies, there was no significant difference depending on the genotype. So I've told you that I didn't find significant differences, and that might seem a bit disheartening. I still have things to look at, and it's important to note that this was just a pilot study with small numbers, so I would like to increase those to confirm. But it's actually a really important finding, because we need to know where we should be investing clinical trial money. There's never enough of it. We'll always want more, so where should it go? It looks like, according to my results, CSF1R wouldn't be the best place to invest in MS treatments. So that's what I have found for this part of my PhD project. And with that, I would just like to thank everyone who's been involved in this research, particularly the funders and the Mater Foundation, who have provided me with extra funding and the Dr. David Cerisier Award. Thank you very much.
Fantastic work, Jen, and congratulations again on your award.
Thank you.
We have time for one quick question from the audience, if anyone has a question for Jen.
So Jen, no findings, no obvious differences, but the mutant receptor, it's reducing signaling, but there are still microglia there. Do you think that you haven't inhibited enough, or do you think that there's just some part of the biology that's not being replicated by simply using that mutant? Do you think there's still microglia could still be a target for MS?
Obviously, this is just one model. Another way to look at it would obviously be to block CSF1R signaling. There is literature where that has been done, and the literature goes both ways. Some say that it's helpful and some say that it isn't. What I'm currently doing at the moment is doing some bioinformatics, which is really fancy stuff, looking at how gene expression changes with computers. And I'm comparing that in my EAE model as well to see if there are differences, and it would be possible to then see, I guess, what signals are changing. Are there other signals that might be better targets? Is it replicating what other trials have found when they've reduced that signaling? Is this a representative model, or should we in fact do it in something else? Yeah. Thank you.
Let's all thank Jen again. So our next two students were awarded the Marta Research International Travel Award, and this was valued at $2,500 each. Our first awardee who is speaking today is Selwyn Samuel. Selwyn is a third-year PhD student in the stem cell laboratory here at Marta, led by Professor Jean-Pierre Levesque. Selwyn has a background in dentistry with an expertise in the field of forensics. His research focus is to investigate the mechanisms by which infection influence the development of neurogenic heterotopic ossification after spinal cord injury. Selwyn has served on the Faculty of Medicine Student Committee and is a Wonder of Science Ambassador. Please welcome Selwyn.
Thanks, Kylie. Feels great to be introduced by your supervisor. So the pathology that we are interested in is known as neurogenic heterotopic ossification. So this pathology is characterized by formation of abnormal or heterotopic bones outside the skeleton, usually in the periarticular muscles, meaning the muscles that surround the joints. This pathology develops after an injury to the spinal cord or to the brain, and sometimes in cases of cerebral strokes, and also to soldiers who have injuries in the spine due to explosive blasts. The problem with this pathology is that it results in complete fusion of the joints that are affected, and that is because the exact cause is not known, which is why there's no treatment, there's no medicines to cure this disease, and the only treatment at the moment is surgically removing these bones one by one. But despite surgically removing these bones can regrow. So that defeats the purpose of surgery. So we really need to know why this is happening to stop this pathology from developing in the first place. So in the meantime, while my laboratory was looking at this pathology and trying to understand more about how to stop this pathology, we came to know that neurogenic heterotopic ossification is more prevalent in patients who have infections. That is, all the patients with spinal cord injury or traumatic brain injury who also had concomitant infections such as pneumonia or smoking habits or bed sores and tracheostomy-like procedures undergone, they seem to have had a higher prevalence of this pathology. So keeping this in mind, we wanted to check if infections contribute to the development of this pathology. So we tested immunogens in my preclinical experiments. I know I've been using this word immunogens quite often. Immunogens are basically substances that are found on the structures of bacteria, viruses, and fungi, which can activate the immune cells and evoke a response. So I tested fungal, bacterial, and viral infections. And I was really surprised to see that all these immunogens exacerbated the volumes of heterotopic ossification in our preclinical models. So to conclude, all viral, bacterial, and fungal immunogens worsened neurogenic heterotopic ossification, which is actually quite consistent with the clinical studies that we came across. So our work definitely advocates more prophylaxis to all the spinal cord injured and the traumatic brain injured victims to prevent this pathology in the first place. And with the award that I've received, I will be presenting at the British Society for Immunology annual Congress, which is happening in Liverpool from the 5th to the 8th of December this year. And this is happening at their convention center. And I really look forward to attending this conference because Liverpool is the hub of Liverpool Football Club, not to mention that I know anything about football. And of course, the Beatles, but I know the Beatles, I love their music. So the benefits of my participation is definitely to raise awareness about this pathology because a lot of people do not know that there's such a pathology, and definitely to showcase the work that's been done in MARTA to show that MARTA research is world-class. And this can definitely attract a lot of global collaborators, which will ultimately increase manpower towards working on this pathology to find better treatment modalities. And definitely on a personal nature, giving me more job opportunities and giving me a chance to converse with a lot of potential employers. And to be a bit more silly, I am also looking forward to go there because I love the British accent. So I can have a lot of conversations with them, not to mention that the Australian accent's the best, which is why I love talking to Paul and Brian. And definitely on a humane perspective, I would love to make the lives of all these spinal cord injured victims much better and help them respond to the rehabilitation strategies in a much better way. Thank you so much. And I sincerely thank all my supervisors and my team and my colleagues and the funders and definitely the MARTA Foundation and the generosity of all the donors, which has helped me receive this award. Thank you so much.
Thank you, Selwyn. And again, congratulations on your award. We can take one question from the audience.
Congratulations, Selwyn. So as you well know, there's a very similar genetic condition, fibrodysplasia ossificans progressiva, that is devastating. And we got a lot of information from that disease to help inform study on this pathology that occurs in spinal cord injury. But I'm wondering whether all the pathways that you've exposed that are important in this pathology, whether you think they will now be able to feed back into the genetic condition and help those individuals as well.
Some of the inflammatory pathways are similar, and some of the cytokines that we've actually pinned down have also been commonly found in both these pathologies, which my supervisor has published on as well. So yeah, so it could be, it can go hand in hand, but I don't think the model that we are working on is an exact representation of the genetic variant, because that requires different types of manipulations to cause the model, but I'm sure there's some relationship.
You can have one quick one. Yep.
Sorry, it's a fascinating topic. Can I ask you, obviously you don't have time to present all of your data there, but you showed that in, I guess, stimulating with both bacterial and viral and fungal, it seems to stimulate the same kind of response. So have you looked into the cytokine or cell populations that are involved in, I guess, those processes? And can you harness that knowledge into perhaps more effective treatment for osteoporosis even?
Could you repeat the last bit?
Oh, sorry. So you're talking about obviously perhaps some underlying pathways, whether it be cellular or cytokine signaling pathways that are involved in heterotopic ossification. Do you know what those pathways are, and is there a way of harnessing that knowledge into treatment for osteoporosis, which is another bony condition?
To other conditions, you mean? To other conditions such as osteoporosis? Like, again, the answer is quite similar to what I previously mentioned. Like, there have been similarities, and a lot of bone pathologies share a lot of common features, but there is some uniqueness to this pathology. But again, you have some, like, for example, IL-1 beta and all these things that are implicated in all these diseases, and there is a bit of similarity. So you can't exactly say that this pathway can be implicated in both diseases to an equally important extent, but they do have some similarities again.
Let's all thank Solon again for his presentation. And so our second awardee this afternoon is Haresh Sajia. Haresh is a PhD student in the immunopathology group led by Associate Professor Sumera Hasnain here at Mater Research. His research focuses on understanding the role of an immune factor released by white blood cells called interleukin 22 in health and disease. Haresh has presented his work at numerous international and national conferences. He also serves on the Mater Research Student Committee and the UQ Faculty of Medicine Student Committee. And his work was recently recognized by a prestigious international travel award from the Cytokine Society to present at a conference in Hawaii. Thank you very much, Haresh.
Thank you, Kylie. So I'm grateful to both Mater Foundation and Mater Research for giving me this International Travel Award. I used this travel award to attend and present my work as an oral presentation at the Digestive Diseases Week in San Diego, California. This conference is the biggest and most prestigious meeting in the world in the field of gastroenterology and hepatology, and was attended by more than 10,000 delegates from all over the world. The opportunity to present and network at this conference have greatly helped my professional development as a PhD student. So thank you again to Mater Foundation. So most of you seated here would have heard of type 2 diabetes. In fact, almost 1 in 20 Australians suffer from this disease, and this number is only set to rise. By 2035, it is estimated that more than 519 million people all over the world would have been diagnosed with type 2 diabetes. However, what most people don't know is that 70 to 80% of people with type 2 diabetes also have fatty liver disease. As the name suggests, it is essentially a disease caused by the accumulation of fat in the liver. Despite the vast number of people suffering from this disease, the best treatment option we have is regular exercise as well as a healthy diet. So just as we can experience stress, the cells in our body can experience stress as well. If there is too much fat in the liver, the cells in our liver can experience stress. In the same way, if there's too much sugar in our blood, the cells in our pancreas that produce the hormone insulin to counteract this can experience stress as well. This stress within the cells can result in organs not functioning well. My lab discovered that a factor released by immune cells called IL-22 can take the stress away and make sure that the cells in the liver and pancreas function better. So my PhD aims to understand the role of this immune factor in our bodies, as well as to see whether we can harness this information to improve the well-being of the hundreds of millions of people worldwide with both type 2 diabetes and fatty liver disease. So we discovered that when we prevented IL-22 from acting on cells that produce insulin, there was a reduction in the quality and quantity of insulin being produced. This led to a high blood glucose level. We also found that the amount of stress within these cells was highly increased. Interestingly, we found that although IL-22 was free to act on the liver, the cells in the liver were also more stressed. This finding highlighted the importance of targeting both the pancreas and liver simultaneously in order to treat fatty liver disease. In fact, we believe that targeting IL-22 to these organs could be the breakthrough treatment that we are looking for to treat both fatty liver disease and type 2 diabetes at the same time. So lastly, I'd like to thank everyone who has contributed to this project, particularly my supervisors, Smira, Mike, John, and Graham, as well as MARTA Foundation and the various funding bodies that have supported us. Thank you.
Thank you, Harish, and again, congratulations on your award.
Thank you.
We have some time for questions. Does anyone have a question from the audience? I'll ask the question.
Yeah.
So with respect to IL-22, what type of cells are responding to IL-22 in the liver and the pancreas?
So that's a good question. With IL-22, in order for a cell to respond to it, it needs to have both the IL-22RA1 receptor as well as the IL-10RB receptor. IL-10RB is more widely expressed, but IL-22RA1 is only expressed mostly on epithelial cells. So within the liver, it's mostly the hepatocytes. We have some data to show that stellate cells as well can respond to IL-22. Within the pancreas, it's mostly, well, it's both the endocrine and the exocrine pancreas, meaning most of the cells within the pancreas respond to that. And IL-22RA1 is also most highly expressed within the pancreas. So that's really interesting.
Thank you very much. Are there any other questions?
Really interesting talk, Rash. So you showed there what happens if you knock out IL-22. As far as the therapeutic side of increasing it, how do you plan to do this first in mice?
Very good question again. So this work is actually partially done by my supervisor, Smira. So she has a spin-off company called Jetra, and they have targeted IL-22 to both the liver and the pancreas. So we do have some very encouraging data from that, but I can't really share too much information because of patents.
At least I tried. Nice talking.
Again, agreed, very interesting. Congrats on your award. So there are a lot of other diseases where organs are becoming stressed as a consequence of the pathology they're experiencing. Is IL-22 only going to be really effective in this particular disease, or does it have other applications as well?
That definitely could work, because we know that IL-22 is a very potent, well, it can relieve stress within the cells very well. So potentially, yes, there are many users for IL-22 currently in clinical trials, including graft-versus-host disease, alcoholic liver disease. So I would think that it is a possibility, yes.
Yeah, I think we might have to finish there. Thank you very much for a
Thank you.
wonderful talk. And I'd like to thank all the speakers this afternoon. If you can all congratulate them as well. Hand back over to Katie.
Thanks, Kylie. I have now the exciting task of inviting you to afternoon tea. So everyone here in person, it's just over in the atrium, and for everyone online, we'll be back at 3:45. And just the judges panel, Paul Dawson will take you off to room 2003 for deliberations. Thanks. Hi, everyone. We might get started. To finish off this afternoon, we have one more lot of talks. And this session's highlighted by Omkar, so I'll just invite him to come up and chair the session. Thanks.
Thank you, Katie. I'm Dr. Omkar Patka, and I'll be chairing the last session of the evening. This year, the Future Leaders Symposium includes a newly created highlight talk session, which gives higher degree research students and early career researchers a valuable opportunity to present their research work to the broader MART research community. HDR students and ECRs have been nominated by their MART research group leaders to present and then selected via a competitive nomination and review process overseen by the MART Student Research Committee. This session highlights our brightest emerging researchers, research leaders of tomorrow. So please give me a chance to introduce our nominees today. The first one is Ms. Jade Kubler. Jade's a current MARTA PhD student in the Mother and Baby program with the Pregnancy and Development Group. Jade has shown excellent leadership within the Queensland Family Cohort team, as well as the Pregnancy and Development team. Jade's an accredited exercise physiologist, an excellent communicator, and was recently a finalist in the UQ 3-minute thesis competition. Present, Jade.
Hi, everyone. Thank you for the opportunity to present some of my some background and some findings from my PhD project today. So there are many physiological changes that occur during pregnancy in order to support the demands of the growing fetus. So we see an increase in energy demand and an increase in the metabolic rate, as well as obvious changes to the musculoskeletal system and changes to the cardiovascular system as well. Some of those changes include an increase in cardiac output, as well as an increase in blood volume. So despite these physiological changes during pregnancy, the guidelines for women are actually the same as those that aren't pregnant. So we see here, there's the same recommendation of 150 minutes per week, as well as strength training and breaking up sitting time. Not to mention that, just as well as that, the guidelines during pregnancy are also the same through each trimester. Now, because of those changes to the cardiovascular system during pregnancy, we see an increase in heart rate as pregnancy progresses, meaning the same absolute workload in the first trimester is actually a lot harder to achieve in the third trimester. So that goal of 150 minutes starts to feel a bit more unachievable as pregnancy progresses. And as well, it starts to feel a bit more uncomfortable for women as they near term. So because of this, we commonly see a decrease in the amount of physical activity that women perform as pregnancy progresses, which can potentially lead to worse outcomes for the mother. So this leads to more trimester-specific research in order to answer the question, could the optimal amount of exercise for improved maternal and fetal outcomes change across pregnancy? So how do we answer this question? We need to assess the effects on the mother, the baby, as well as the organ that connects the two and facilitates the growth of the fetus, which is the placenta. And so my research is centered around the placenta with two primary aims of looking how physical activity volume and conversely sedentary behavior affect placental morphology and function. So sedentary behavior is different to physical activity. So sedentary behavior is related to the amount of time spent sitting. So women can actually be both physically active and sedentary. So we hypothesize that a higher volume of exercise may not actually have any additional benefit on placental outcomes, or could potentially lead to detrimental effects with an excessive volume due to the competition in energy demand between the mother's musculoskeletal system during exercise and that blood supply to the fetus. Conversely, we expect to see negative effects on the placenta associated with sedentary behavior during pregnancy. So in order to begin to answer that question, we began with a systematic review and meta-analysis, which pulled data from a lot of the previous research. And one of the measures we looked at was placental weight, so how big a placenta is. And what we saw with all of this data was that there was no change in placental weight between those that exercised during pregnancy and those that didn't, which you can see here in this graph with the little diamond at the bottom crossing 0, meaning there was no difference between the groups. This was supported by some of our findings in the Queensland Family Cohort Study, where we matched physical activity and placental outcomes in over 200 women, and we saw no change in placental weight with any volume of physical activity performed at 24, 28, or 36 weeks of gestation. Another thing that we looked at was the expression of placental growth factors. So those growth factors are responsible and contribute to the growth of that placental tissue, and may have an effect on that end placental weight. And so what we saw was no change in placental growth factors based on the physical activity that was performed in that late pregnancy period. On the other hand, when we looked at sedentary behavior, we saw some sex-specific effects with this adverse environment. So sex-specific meaning based on if it was a male fetus versus a female fetus. So in males, we saw that placental weight was associated, a decrease in placental weight was associated with sedentary behavior. which was consistent with a reduction in placental growth factor based on that sedentary behavior again. So we see that reduction in growth in males associated with sedentary behavior. However, in females, we saw no change in placental weight and an increase in these placental growth factors based on those women that were sedentary during their pregnancy. So this data is starting to suggest that these female placentas are more adaptable to this adverse environment than those male fetuses. So overall, it may not matter what you do in late pregnancy in terms of placental outcomes, as we saw no change with any particular volume. However, sedentary behavior may be the greater risk where we see that adverse environment in the placenta. In addition to this, we are also starting to see those sex-specific differences where females may be more adaptable than males. So where to next? We looked at the later half of pregnancy with our research. So future research should focus on more of the periconceptional period, so that pre-conception and early pregnancy period, and seeing if there is some sort of programming effect that occurs with these behaviors on the placenta. Also starting to look at placental function. So we've looked at how exercise and these behaviors start to affect the growth and the size of the placenta, and further research should focus on the function. This can all be applied to clinical populations where it's going to be really important to minimize these risk factors in order to improve pregnancy outcomes. And all of this data can begin to guide us towards more trimester-specific guidelines in order to increase that participation in physical activity as we progress through pregnancy. So I would just like to acknowledge everyone that was involved in this project and all the families in the Queensland Family Cohort Study that made this project possible, as well as a big thank you to Mater Foundation for their ongoing support.
Thank you, Jade, very much for the beautiful talk. We've got time for 1 or 2 questions. Natasha?
So the question was the sex-specific differences in the placenta weight, and was it related to the total placenta or the embryonic portion of it? So it was just total placental weight that we looked at. So we just, I guess, in terms of the protocol, we just had the placentas collected at delivery and were measured there. Yeah.
One question.
Thanks for that nice talk. Did you also look at the baby weight to see if the males with the smaller placenta, if it affected the actual, baby weight or anything like that?
Yes. So I did look at birth weight, and I think what is also commonly seen in the literature is that males are bigger at birth, which is what we saw as well. So potentially there are other mechanisms going on to support a healthy development of the baby. So I guess we see there's that reduction in placenta weight with males. Potentially there's that compensation with a bigger baby to support their growth, but under investigation.
Thank you.
Thank you, Jade. Please welcome our second nominee, Mohammed Sabdia. Mohammed is a PhD student at Mater Research in the Cancer Program with Blood Cancer Research Group. Mohammed has recently passed his first confirmation milestone and has had a first author review article published in Blood Reviews already. Mohammed was an RA for 3 years before starting his PhD. He's self-driven and has demonstrated a real passion and drive for scientific research.
Good afternoon all. Thank you for that, Omkar. I'd first like to start off by thanking the Mater Research Student Committee for this opportunity to share with you all some of my PhD research on how we can recruit the immune system in the fight against chronic lymphocytic leukemia. So chronic lymphocytic leukemia, or CLL, is the most common adult leukemia with approximately 5 new cases diagnosed each year in Australia alone. CLL is typically a disease of the elderly and usually affects people around the age of 65. CLL is a type of disorder that can either be slow growing and hang around for many years, or it can be fast growing. And because of this, treatment and management of patients with CLL is quite diverse and can vary from patient to patient. New treatments for CLL have improved patient outcomes, but despite this, almost all patients either have the disease come back, which is known as a relapse, or not even respond to treatment, creating a cycle of disease and relapse. But even, despite advancements in the treatment of CLL in recent years, CLL is still considered to be an incurable disease. So how can we improve the outcomes for patients with CLL? Firstly, we have to know about the current treatments, which are a part of a class known as inhibitor treatments. These inhibitors work by targeting the cancerous, targeting pathways in the cancerous CLL cells and stopping their ability to grow and survive, effectively killing the CLL cells. Now, these inhibitors have drastically changed the outcomes for many patients, particularly those who have the fast-growing type of disease. But these treatments aren't without their downsides. These treatments are not curative, and treatment is also costly and required long-term, usually until the disease returns, often of which, when that happens, these inhibitors are no longer work. So how can we improve these outcomes and get the tumor cells under control? One interesting avenue is that these treatments change the balance of our immune system, which is responsible for maintaining a line of defense against the cancers. So before treatment, the balance of the immune system shifts towards more of a supportive role for the tumor cells. But after treatment with these inhibitors, what happens is the balance shifts away from supporting the growth of the tumor cells and gains the potential ability to start getting rid of these CLL cells. So whilst the new inhibitor treatments prolong periods of remission, they are expensive and non-curative. And perhaps by recruiting the immune system in patients with chronic lymphocytic leukemia, we can improve patient outcomes. So how can we recruit the immune system? Firstly, we have to know how it works. The immune system works to recognize bad cells through interactions between proteins on the cells and our immune cells. So in normal circumstances, the normal cell expresses a normal protein, which tells the immune cells that they're good to go and to leave them alone. However, in cancers such as CLL, there are changes to some of these proteins that are unique to the CLL cell, and we call these neoantigens. These neoantigens are specific to the CLL cell, and in most cases are unique to each individual patient. Now, if the immune system works correctly, the precise immune cells are able to recognize these neoantigens and eliminate the cells that have these neoantigens. But this system isn't working correctly in patients with CLL, even after treatment, and the immune cells aren't able to effectively eliminate the CLL cells on their own. So despite these neoantigens being unique to the CLL cells, for some reason, the immune system is switched off towards the CLL cell and doesn't work against it. So this brings me to my research question. How can we improve and refocus the immune system in patients to recognize and kill the CLL cells? So to answer this question, I've performed sequencing on CLL cancer cells and healthy cells using high-performance computers, and I was able to identify that these neoantigens are from proteins that are unique to the CLL cells and not present in normal cells. So whilst this diagram is very nice and straightforward, this process is very technically difficult, and but this area is becoming increasingly streamlined and in the near future could become routine practice. But because this work was done using computers, I next aim to spend the next 1.5 years of my life trying to show that these neoantigens can be made to be recognized by the patient's own immune system. And I'll aim to show that with the right conditions, we can actually work to remove this block. We can remove this block and make the immune system work against the CLL cells and actually start killing the CLL cells in the lab. So what could this mean for patients with CLL? So with the change to a more anti-CLL immune system after treatment with inhibitors, by educating and recruiting the immune system through CLL neoantigens, this research will hopefully provide a new way to help treat patients with CLL. And the framework of this study could also be applied to other blood cancers to improve outcomes of patients diagnosed with other cancers. With the ultimate goal, with the ultimate goal of this research aiming to show that by recruiting the immune system through neoantigens, we can improve outcomes for patients with chronic lymphocytic leukemia and perhaps even lead to a long-term cure for CLL. I'd like to thank everyone in the Blood Cancer Research Group at MARTA and my supervisors, Mahia, Anne-Marie, and Christian, as well as I'd like to thank the MARTA Foundation for providing invaluable support to my group and through the Frank Clare Scholarship that allows me to conduct this cutting edge research. Thank you.
Thank you, Mohammed, for that wonderful talk. We've got time for a question. Brian.
Nice work, Mohammed. By increasing the level of these neoantigens, do you think that'll be sufficient to overcome the immunosuppressive environment that almost all cancers have that make them invisible to the immune system?
Yes, so there is some preliminary data showing that after treatment with these small molecule inhibitors, the entire immune microenvironment does change to be more conducive to the immune cells recognizing the neoantigens, but for some reason, it's not happening naturally. So there's an avenue for neoantigen-based vaccines to sort of kickstart that immune-based response. And it's been shown in cancers like melanoma, which have very high numbers of neoantigens, that a simple immune boost via vaccination can actually invoke this immune response.
Thank you, Mohammed. Our third speaker for today is Dr. Amelia Ingham. Amelia is a research scientist at MARTA Research with the Chronic Integrated Care Program in the Glycation and the Diabetes Complications Group. Amelia's research is focused on finding new medicines to prevent and treat type 1 diabetes, kidney disease, which can result from diabetes. This involves partnerships with clinicians, engineers, biotechnology companies, and people affected by diabetes. In her spare time, Amelia is a new mom and enjoys singing as a part of the Brisbane Concert Choir and Fusion Vocal Ensemble. Amelia.
Thanks, Omka. My little boy and the constant barrage of childcare illnesses is making me feel more like a future disaster than a future leader, but I'll endeavour to convince you otherwise. So this is the Glycation and Diabetes Complication Group. Despite my absence in the photo, I am part of a member of this team. And as our name suggests, we're passionate about diabetes. Why are we passionate about diabetes? Well, it's one of the most prevalent chronic diseases here in Australia, but much of the developed and developing world, with up to 1 in 5 Australians over 75 having diabetes. Not only that, it costs a whopping $2.5 billion annually to the Australian healthcare system, is the leading cause of heart disease, kidney disease, and stroke. And kidney disease is what I'm going to be talking to you about today. And why we're interested in that is because as kidney function declines in patients with diabetes, their risk of mortality and death drastically increases. Diabetic kidney disease affects about 30 to 50% of patients with diabetes, depending on the cohort you look at. It's characterized by a decline in the ability of the kidneys to filter, leakage of proteins that we shouldn't see or wouldn't expect to be in the urine, and essentially a number of changes that are just fancy words for scarring or damage to the kidney tissue. And whilst we have some good first-line therapies focused around glycemic control and blood pressure, they only slow disease. So there's a big therapeutic gap that scientists have been trying to address for decades. So why is the kidney vulnerable in diabetes? Well, while you're sitting there listening to me talk, your kidneys are actually working really hard. They're filtering and reabsorbing solutes, nutrients, and ions that have been filtered from your blood. And all of this requires active transport. And as the name suggests, active requires energy. So just like we've invented solar cells to convert energy that we can't readily use, light from the sun, into an energy source that we can use to charge our iPhones and power our appliances, the cells in our body have mitochondria. Now, these mitochondria are able to convert a fuel source that our cells aren't quite so readily able to use, things like glucose and fatty acids in conjunction with oxygen, into ATP, a source of fuel that our cells really like to use. And our kidney, because it is such a busy organ, actually requires a lot of ATP just for normal function. So as such, kidney cells have a lot of mitochondria, and they're actually the second largest consumer of oxygen at rest. However, in diabetes, a number of changes occur, including a disruption to the delivery of fuel, things like glucose and fat to the mitochondria. We see a huge increase in the demand put on the kidney. And we see things like a lack of oxygen or hypoxia develop. And all of this culminates in what's known as mitochondrial dysfunction. And we know this is one of the underlying pathways that lead to the development of kidney disease, and it occurs quite early in the development of diabetic kidney disease. So to try and target this, we've been trialing a therapy called Mito-A. It sort of restores the balance, if you like, to the mitochondria and helps them cope with the extra stresses put on them. It has several advantages. It's actually already undergoing clinical trial. So we already have a lot of safety information about this compound. And we also have some data around diabetic patients. And this helps us understand how to dose and how to think about this compound. And then the other big advantage is it can be taken orally. So the aim of this study was to understand whether this compound could provide renal protection in experimental type 2 diabetes. So as part of the regulatory pipeline, we of course have to test efficacy in preclinical models. And the preclinical model that we chose was a model of obesity and type 2 diabetes. They're a mouse that overeats and develops enormous weight gain and develops type 2 diabetes. And importantly, they develop a number of the chronic complications of diabetes, such as kidney disease. So for this study, we took both their healthy counterparts, but also our obese type 2 diabetic mice. We had mice that received a placebo, we had mice that received our treatment, and we had mice that received the standard first-line therapy that we know works. We looked at kidney function and then did a whole lot of really fun things in the lab at the study and to best understand what was going on in the kidneys and the bodies of these mice. Much to our delight, we found that indeed our treatment did slow or ameliorate the progression of kidney disease in this model. Here we used a measure of leakage of protein into the urine, and that was our primary endpoint. We also saw improvements in a number of structural markers that we looked at with our treatments. But what was going on in the mitochondria? We used a fun technique to characterize the individual cell types, as there's multiple cell types that make up the kidney, and had a look at the amount of a mitochondrial protein to get an idea of the mitochondrial density or volume, if you like, of these cells. And what we found was, interestingly, our treatment seemed to consistently increase or tended to increase the mitochondrial density in a number of the cell types that we looked at. And we were able to confirm this looking under the microscope. So in green, we have our mitochondrial protein, and then we have a number of markers of different cell types in the kidney. And you can see with our treatment, we get a much brighter green, if you like, compared to our placebo receiving kidneys from placebo receiving mice. So, you know, we're able to confirm this both using two techniques, including one that gives you a nice visual. And when we go even closer in, so right down to the teeny tiny world of the organelle, we were able to see that our mitochondrial therapy helped prevent some of the negative changes we see in the mitochondria, such as this swelling effect that you get with mitochondrial dysfunction in diabetic kidney disease. So what does this mean for patients? Well, our end goal here is to find a therapy that we can progress towards clinical trial. And this research has allowed us to gain more funding to repeat this study in more aggressive models of diabetic kidney disease. And it's also helped working towards getting a patent for these compounds to so that we can get them into clinical trial. So hopefully we will work towards having another therapy option out there for patients with diabetic kidney disease. I'd like to thank all the members past and present of the Glycation and Diabetes Complication Group, but especially those that work directly on this project. Thank you.
Thank you very much, Amelia, for that. Have time for a few questions. Ali.
Really nice talk, Amelia. So I think I noticed when you were comparing it to the standard of care, your new treatment was probably not quite as good as the current standard of care. Do they attack different pathways? And if you combine them together, would this perhaps create a super therapy?
I mean, that is always our end goal, is to find, so yes, they do attack different pathways. So the therapy we use there as a control is like a blood pressure lowering agent. So we have looked at combined therapy for a 7-minute talk. The findings were a bit up and down. Some things they were improving collectively, and other things they were sort of negating each other's effect. So it gives us a lot of information about what sort of pathways that we might be targeting. And we're trying to do a bit more work to better understand. And that's why we're running this again in different models to try and.
And do you know if you're using your optimal dose yet?
No, I would say no. We did have dosing information for that was developed in normal mice, but I think with an obese model, you get a lot of issues, as well as a model with kidney impairment. Yes, so we actually are doing some work to come up with a better dosing strategy that may be more specific for diabetes and diabetes with renal impairment.
Lovely. Thank you so much for the talk, Amelia. Our next nominee is Alicia Martin. Alicia Martin is a Martin Research PhD student in the Healthcare Delivery and Innovation Program with the Allied Health Group. Alicia is leading the development of TINSA, a transdisciplinary neurological screen at the Mater Acute Stroke Unit. Alicia is a recipient of the NHMRC PhD Scholarship, a Queensland Health Research Grant, and a Betty McGrath Healthcare Delivery Innovation Seeding Grant. Please welcome Alicia.
Thank you, and good afternoon, everyone. As you heard, my name is Alicia and I work as an occupational therapist at the Mater Hospital on the Acute Stroke Unit. And it's my work on the Acute Stroke Unit that inspired me to do my PhD evaluating transdisciplinary stroke assessment. So stroke is a big problem for many people. In fact, in 2020, over 27,000 Australians experienced a new stroke for the first time. And this number is expected to exceed 50,000 by 2050 without action. Now, these are big numbers we're talking about, but it's also important to remember we're talking more than just about numbers. We're talking about people, their lives, and their experiences. This is a picture of the acute stroke unit where I work at the Mater. It's an open 7-bed bay, and our patients experiencing stroke symptoms are transferred here as soon as possible. People experiencing stroke symptoms could experience confusion, loss of vision, inability to talk, difficulty swallowing, difficulty walking, difficulty using an arm, a leg, loss of balance, just to name a few. We know for stroke that time is critical. In the stroke research, early assessment and intervention are linked to better outcomes for our stroke patients. And in fact, the acute stroke guidelines state that every stroke patient should receive a physiotherapy, speech pathology, and occupational therapy assessment within the first 48 hours of hospital admission. Now, each of these assessments can take up to 60 minutes. So when you total it up, that's up to 180 minutes of assessment time on day one at the hospital. That's a lot of assessment time, especially for somebody who's just experienced a stroke. But the story doesn't end there. We also know from patient and staff experience and report that there are a lot of duplicated questions and tasks within these allied health assessments. For example, the occupational therapist and physiotherapist both assess arm function, and they both ask about the home environment. This is where my PhD comes in. I aim to reduce the duplication across these assessments and to improve the time efficiency and patient care and experience. To do this, we've developed a new transdisciplinary stroke assessment, which we have implemented on the acute stroke unit. And I hypothesize that compared to usual care, this new transdisciplinary assessment will save at least 20 minutes of assessment time. So what is transdisciplinary assessment? Well, I'll use this 3-in-1 utensil to help me explain. So as you can see, this utensil combines a knife, a spoon, and a fork. And it does that to save us weight and space in our bags when we're camping or hiking. Our transdisciplinary assessment at the Mater is very similar to this utensil because it combines occupational therapy, physiotherapy, and speech pathology assessments into one comprehensive assessment that can be delivered by one clinician. Our study on the acute stroke unit is still ongoing, and it's due to wrap up at the end of the year. So while we haven't done any statistical analysis yet, we do have some promising preliminary findings. On the slide in the bold, you can see our primary outcome of staff time savings. And when you compare usual to transdisciplinary assessments, you can see that there is a 53-minute time saving per patient when the transdisciplinary assessment is used. We're also looking at other outcomes, such as to do with patient quality of care. So for example, time from admission to assessment. And you can see that a lot of these outcomes are fairly equivalent at this stage. But it's important to note that the 23 hours, the equivalent outcome, is still a good indicator of quality stroke care, as it's within that 48-hour time frame that the stroke guidelines suggest we should do. Other outcomes we're looking at are adverse events, such as patient falls. Once again, you can see they're equivalent. There are 0 patient falls recorded between the groups. And we're also asking patients about their satisfaction with the assessment processes. One question we're asking them is if you experience repeated questions across the assessments. You can see that a very small number, 8% in the usual assessment group, said that they did not receive repeated questions, compared to a much larger percentage in the transdisciplinary group, 42%, who said that they did not receive repeated questions. Beyond these outcomes, we are looking at a bunch of other things like length of stay, staff satisfaction, staff trust, as well as patient function and patient quality of life. So where to from here? Well, I hope that we can continue using this transdisciplinary assessment at the Mater Acute Stroke Unit beyond the clinical study. And I also hope to understand the translation needs of other healthcare clinicians in other healthcare settings to be able to best share my research to help them improve healthcare in their settings as well. I'll finish with a few acknowledgements, firstly to my advisory team, as well as the staff at the Mater Hospital and Active Rehabilitation Physiotherapy for their dedication and commitment to the project over the last 2 years. And also for the financial support received from funding bodies, including Mater Foundation and Mater Research. Thank you.
Thank you, Alicia, for this wonderful talk. Time for a question. Got my hair.
Very nice work, Alicia. Do you think that patient satisfaction can be increased if you could combine some of the nursing and medical assessments, because there must be some cross questions there as well?
Yeah, great question. Yes, I'm sure there is even greater scope to combine even more assessments than what we're doing now. And I guess each setting will be different as well as to the feasibility of doing so. At the Mater, we started with just allied health as it was seen to be more feasible, especially, for example, the nursing staff have a hospital-wide nursing care plan. So to be able to change that process would require a lot of discussion. So we thought we'd be better off starting small and building the evidence and going from there.
I'll just ask you one quick question, Alicia. How did you and your team develop this transdisciplinary assessment?
Thank you for the question. So this transdisciplinary assessment was developed through a fairly large process. We spent probably over a year developing and refining it. And a few of the things we did was firstly grabbing our usual allied health assessments, highlighting everything that was duplicated, and then highlighting other questions that could be shared safely between professions. From that, we combined them all, made the assessment, and then went through a couple of rounds of simulation testing to be able to process test and make sure the assessment was doing the right thing, had good flow, and wasn't too long.
Thank you so much for that. So next, our final speaker for today is Dr. Kavita Bisht. Dr. Kavita is a research officer in the stem cell biology group at Mater Research. Kavita's research focuses on identifying new treatments for blood cancers and anemia of inflammatory diseases. Kavita is a recipient of several awards, including the Equity Trust Award from Mater Foundation and the Franklin Women COVID-19 Carers Support Scholarship. Most recently, she was also awarded the American Society of Hematology Global Research Award. So please welcome Kavita.
you, Omkar. Good afternoon, everyone. First, I would like to thank the organizer for giving me the opportunity to present one of my research interests. So just before I start, I just want to tell you about our team. So it includes myself, and I work under Professor John Pierre, which is a group leader at Stem Cell Biology based at Mater. And this project is a collaboration between our team and inflammatory bowel disease, which is led by Associate Professor Jake Bigan and also Dr. Yun. And I would like to thank Mater Foundation for their generous support, as well as other funding body for supporting this project. So I want to start this slide by mentioning this quote, which says, "Anemia is like suffocating from the inside. Every organ and system being affected. Lack of oxygen makes it hard to live energetically and enthusiastically." And sadly, 1 billion of world population is currently living with anemia. So what's anemia? So as I'm talking to you and while you're listening to my talk, your stem cells in your bone marrow is busy making your red blood cells. And we make every second, we make 3 million new red blood cells. And when you produce less than that, you become anemic. And there are some of the symptoms. What happens? You become anemic. Your skin becomes pale. You have low hemoglobin. You feel tired all the time, and you don't want to do anything. You have shortness of breath, cold hands and feet, and you have impaired transport oxygen from your lungs to other organs. And you feel dizziness or headaches. However, anemia goes beyond these symptoms. And if it gets severe, it can lead to multiple organ failure because organs such as hearts and kidneys do not get enough oxygen, and that can cause an early death. So there are some of the causes of anemia. It can be caused by parasites such as malaria, or mutations, intestinal bleeding, iron deficiency, and also some infections such as tuberculosis, sepsis, salmonella can also cause anemia. And anemia is also prevalent in one of the chronic diseases called inflammatory bowel disease, or IBD. And I'm interested in understanding anemia in IBD. So what is IBD? So IBD is a chronic, relapsing, progressive inflammatory condition of the gastrointestinal tract. There are two main types of IBD. One is ulcerative colitis, which is limited to the colon, and it's a continuous ulcerating inflammation. And the second type is Crohn's disease, which can occur anytime, anywhere throughout the gastrointestinal tract. So the patients with IBD, they suffer from abdominal pain, diarrhea, rectal bleeding. And they also have loss in appetite, weight loss, and they also have fever. And on top of these, 30% of IBD patients are anemic, and they live with poor health, chronic fatigue, and poor physical state. And half of these anemic IBD patients do not respond to current treatment for anemia, which include transfusion with red blood cells or iron supplements. And anemia in IBD is one of the leading factors for increased hospitalizations. So in this project, the hypothesis is that the molecules which is produced by gut bacteria stays in healthy gut. However, in IBD, the gut becomes leaky, which causes this bacteria to enter the blood and leads to anemia. So my hypothesis is that in IBD, the leaky gut causes anemia, one, by increasing inflammation, and two, by increasing red blood cell degradation in spleen. So to prove my hypothesis, I developed a preclinical model of colitis. And you can see here the bone marrow. So if your bone marrow is red, means you have enough red blood cells there. As I mentioned, that bone marrow, stem cells in the bone marrow makes all our blood, immune cells, and red blood cells. And if this bone marrow becomes pink or pale, suggests there's the indication of anemia. So we looked at in our preclinical colitis model, and what I found that in the healthy bone marrow, the bone marrow is red, but following colitis, the bone marrow becomes light pink. And the number of red blood cells were also decrease after colitis. So this suggests that colitis causes anemia. And then I also looked at the leaky gut. So I looked at the endotoxins and the inflammation, and I found that after colitis, there's an increased amount of endotoxin in the blood, and there's an increased inflammation. So this suggests our hypothesis that leaky gut causing an inflammation leads to anemia in IBD. So the aims of this project now, I want to test the drugs which can target this leaky gut or the inflammation, as well as the degradation of red blood cells by spleen. So I expect that targeting these pathways, I would be able to alleviate anemia in IBD and improve the quality of life of IBD patients and provide better care to the patients with IBD who have anemia. So no one suffocates from the inside, no organ and system being affected, and there's no lack of oxygen, and everyone lives energetically and enthusiastically. And with this, I would like to thank, and I'm happy to take any question. Thank you.
Thank you so much, Kavita. We've got time for a few questions. Just one question.
Okay. Thank you, Kavita. Nice talk. I have a question. You have a figure there that you have. There is.
Sorry, I can't hear you, Shwetlana.
Do you hear me now?
Yeah.
Better? Okay. You have a figure there that there is increased inflammation. What did you measure for that? And did you look at cytokines? What does it mean, the numbers?
So the inflammation, if you have inflammation, your body produces these molecules called cytokines. So we looked at different cytokines, and one of the key cytokines in anemia is called interleukin-6. And this is the one I found really increased after colitis.
I'll ask you a quick question. Can you infer on the mechanism as to how colitis affects the bone marrow? Anything?
So Omkar asked me the mechanism how colitis affects the bone marrow. So the mechanism, so I'm looking at the role of macrophage, which is immune cells in the bone marrow, because in our bone marrow, there's a macrophage called blood island macrophage, which is very important for supporting the red blood cell formation. And in our previous study with infection, we found that this anemia is caused, infection causes anemia via these macrophages. So we will be looking the mechanism by using a specific model where we have this deleted macrophage and, sorry, we have a receptor deleted in this particular macrophage, and we'll be investigating. And this receptor is very important for endotoxins or leaky gut. So we'll be looking at that.
Thank you so much for that, Kavita.
Thank you.
This ends this session. Please join me in thanking all the speakers, and I'll hand the floor to our MC, please.
Thank you, Omkar, and to all the presenters for those engaging talks. We're nearing the end of the afternoon, so I'd like to invite Paul Dawson to come up because he's got the very important job of announcing the ECR winners.
Thanks, Katie. And it's my privilege to announce the winners of the Early Career Researcher seating grants. And I'd like to ask Judy Renouf to come up, who's going to present the first certificate. While Judy's coming up, I'd just like to remind you that this seating grant scheme is designed to build capacity and provide an opportunity for our early career researchers who have upheld the Mater research tradition of research excellence, and will also enable them to be more competitive for national or international grant funding. So we have two competitive seating grants of $15,000 each are available in this year's scheme. One is awarded for a biomedical project, while the other is awarded for a clinical or health services research project. And it gives me great delight to announce that the winner of this year's clinical seating grant is Grace Branchapur. So while Grace is coming up, the judges were impressed by the research project that has the potential to save lives and improve women and improve perinatal mental health outcomes. So well done, Grace. I'd like to ask Darren Armstrong to come up, who's going to present the Biomedical ECR Seating Grant Award certificate. It's my pleasure to announce that this year's ECR Seating Grant recipient in the biomedical category is Natasha Jantz. So while Natasha's receiving a certificate, the judges were also impressed by Natasha's work that impacts on a considerable number of Indigenous Australians and a virus that we need to know more about that will inform future research and improve health outcomes for those vulnerable people. Thank you. The next group of certificates that we're going to hand out are for the HDR Student International Travel Awards. And I'd like to invite Brian Gabrielli up to present those certificates. The first certificate named, or the award named in memory and honour of Dr. David Strizia is awarded to Jennifer Stables. Congratulations, Jen. And that's a $5,000 award to assist with international travel to that conference that Jen mentioned earlier today. Well done. The first of the just international travel awards, $2,500, if I get that correct, goes to Selwyn Samuel. Congratulations. And Selwyn will be travelling over to the UK, home of the Beatles and the Liverpool soccer team. Congratulations, Selwyn. And networking. An important area of research, heterotrophic ossification. Selwyn's done a terrific job during his PhD. Well done. Our third International Travel Award goes to Haresh Sajir. Congratulations. Come up. So Haresh travelled in May to an international conference, one of the biggest in the gastroenterology field. So well done, Haresh, to present your work. So that just leaves me. We're running a little bit behind schedule, so I'll cut to the chase. I just wanted to thank everyone that's come along today. I think the quality of the presentations and the breadth of the research was phenomenal. Everyone's done an amazing job here at Mater Research, and the many people that have made today a success. So obviously the attendees, thank you all for coming, for those that have joined us in person here in the auditorium and also online. To our presenters, without you, this would not have been possible. It's been an amazing day. And in particular, I just wanted to congratulate Dr. Lisa Gillender and Mr. Casey Lucas for giving the Professor John Prins Oration this morning. I think it really speaks highly of having a clinician and a patient present at the same time. And we will continue that into the future. There are many people who've run today's event in such a successful way. The event support team led by Farhan and Maiten, congratulations to everyone involved there. Our judges for the ECR Seating grant, the panel, Judy Renouf, Ruby Dollar and Darren Armstrong, thank you so much for giving up your valuable time today and coming along. MC, Katie Brooker, well done, Katie. Katie was called in at the last moment. Loretta Weatherall for giving the Acknowledgement of Country today, well done. And obviously Marta Research and Marta Foundation, who have supported all of you through your journey and your research endeavours to make you all where you are today. I'd just like to remind certain people to stay behind in the auditorium for a short period of time. We're going to take some photos. The Marta Research Executive. I'd like to ask the judging panel members, as well as the all of the presenters, the winners, including all of the other presenters, to come up, and we're going to take some photos. And then following this, we've got some maxi taxis leaving the front of the TRI building, taking people to the brew house for our networking event. They should be arriving from about 10 to 5 onwards. So for those people that are not getting their photos and going to the brew house, can you please proceed up? Thank you all again for such a wonderful day. It's been a success, and I look forward to more of these events into the future. Thank you so much.